Thank you. So I'm a practicing physician like you. So the topic when we were given by Dr. Weil, I had to go back to my own textbooks to read about a lot of changes which have happened since I did my medical education. So I'm only talking about pathophysiology, and this is the outline of the talk. And hopefully, if you're going to have some four key takeaways, you're going to go home with these four concepts. Insulin resistance is a central driver of vascular endothelium dysfunction and altered renal hemodynamics. Chronic inflammation, and I'm going to talk about how adipose tissue is an endocrine organ itself and how it triggers chronic inflammation. I'm going to talk a little bit about oxidative stress, and maybe we'll have some molecules in the future which will hopefully prevent atherosclerosis, but oxidative stress is the main driver for atherosclerosis and nephrosclerosis, and how renal angiotensin system and sympathetic activation are correlated and cause heart failure, hypertension, and metabolic syndrome. So as Professor Noshi alluded, the American Heart Association came back with this new concept called cardio-kidney metabolic syndrome, and there are 5 stages. Stage 0, which is no risk factors. Stage 1, when people start putting on some weight, and the adipose tissue drives the inflammation, drives the activation of various cytokines and inflammatory processes which lead to downstream effects. So as physicians, we are seeing patients in stage 4 in clinic, but to solve this problem, we need to think about in a more holistic approach to reach people upstream so that they don't end up in hospital like this. And I would encourage you to read this an article which came out from In Circulation. This is a position paper of how we should rethink how we manage these conditions, which are currently managed in silos. It's a big problem. We know that. 10% of the world population has kidney disease. 64 million people have heart failure. And as you know, these patients are the ones who are the frequent flyers in your hospital. And they cause a lot of morbidity. They cost a lot to healthcare systems. Now, if you think about how hospital systems are funded, we think we are making money, but actually the society is get affected when working population gets affected with these kidney disease, and downstream there's a big societal impact. Just so there's a study which came out from a part of India I'm from. 50% of general population has kidney disease. So these are working population, you know. So the first key concept to take home is insulin resistance. And this is the primary metabolic effect causing obesity, type 2 diabetes, and peripheral cardiovascular disease. And as when you have insulin resistance, you have impaired glucose uptake, which promotes hyperinsulinemia, driving vascular and renal damage, which I'll come to. There's, of course, cardiovascular impact with atherosclerosis, hypertension, myocardial dysfunction. And of course, insulin resistance directly involved in impact on renal hemodynamics, which leads to proteinuria and CKD. So, of course, there's a normal physiology. So what is postulated is when you have insulin resistance, you have hyperinsulinemia, high glucose, and because insulin is required for glucose metabolism, and there's insulin resistance, you start breaking down fat. All this causes oxidative stress, direct lipotoxicity, and of course leads to cell death. And also there's a direct impact of insulin resistance on endothelial dysfunction. Normally insulin helps glucose come in, but when you have insulin resistance, there's glucotoxicity, lipotoxicity, inflammation. All this breaks the balance we have in our body about vasodilation, vasoconstriction. And when you have free oxygen radicals, they inhibit the endothelium to nitric oxide synthase, which means that the balance is tipped over towards vasoconstriction, and that's causing hypertension and other end organ damage. So in summary, with insulin resistance, you have impaired nitric oxide production, pro-inflammatory shift, thrombogenic impact, you have platelet activation, and oxidative stress. There's also a specific insulin impact of that insulin resistance on kidney and kidney vasculature. And kidney, as you know, is evolutionary and modified artery. and 20% of cardiac output goes to the kidney every beat. So when you have impact and you have vasoconstriction, that triggers many pathways which we all know about. There's one more, of course, as we all know, SGLT2 inhibitors have been a game changer. But again, the idea is when you have hyperinsulinemia and insulin resistance, it means that there's a lot of glucose reabsorption and there's metabolic stress on the principal cells in the distal colonnade tubule, which in the end have cell death and senescence and then interstitial fibrosis. Hence, these SGLT2 inhibitors are so impactful in reducing kidney disease. So again, in summary, insulin resistance impacts renal GFR, impacts the hemodynamics, and it causes metabolic overload in the proximal tubule and the distal colonnade tubule, which causes tibial interstitial hypoxia and fibrosis. Hence, these SGLT2 inhibitors are such a game changer for our medication. So one more concept to take home with, insulin is also responsible for hemodynamics. And once you have insulin resistance, that counter loop system which is inbuilt, it goes away. And then you have these hormones like angiotensin, endothelin, cytokines start causing vasoconstriction. And over a period of time, it causes hypertension-induced target organ damage, then of course, other downstream effects. So again, the main concept is if you have insulin resistance, you have RAS activation, a sympathetic overdrive, hypertension, all leading to end organ damage. Now coming to the second concept, that adipose tissue is an endocrine organ, and that can trigger a lot of pro-inflammatory state, which causes multiple organ system. So when you have dysfunctional adipose tissue, it leads to inflammation, oxidative stress, insulin resistance in itself, and vascular dysfunction. All this affecting the heart, the brain, and the liver, and the kidneys. So this concept is that when you have excess adipose tissue, it leads to chronic low-grade inflammation, which is this unifying mechanism which leads to end organ damage in every vascular bed. And there's also immune metabolic crosstalk, and we'll talk about that briefly in the subsequent slides. And of course, the end organ damage we talked about. So what happens? So when you have the fatty tissues, excess fatty tissues, the adipokines levels go down, and then you have excess saturated free fatty acids, causes hypoxia and cellular inflammation, the cellular death, leading to inflammation, and again, which causes insulin resistance. So this is this overriding idea that the adipose tissue is not the end result of insulin resistance, but actually drives a lot of these processes we talk about. Interestingly, this concept was kind of new to me, whereas that the perivascular adipose tissue also influences vascular function. And we know that when the cardiologists and the bypass surgeons and the vascular surgeons talk about how these arteries become stiff, difficult to do bypass, difficult to do angioplasty. So what happens is, in insulin resistance, the protective adiponectin levels goes down, the pro-inflammatory hormones go up, there's endothelial permeability, then you have this proliferation of vascular smooth muscles, all this causing the arteries to become stiff and with the resultant end organ damage. So again, the concept, the adipose tissue is an endocrine organ where you have endocrine dysfunction affecting both innate immunity and inflammatory response. So what happens when you have all this inflammation? You have changes in the extracellular matrix, you have changes in the vascular smooth muscle. All this will cause fibrosis, and also this unfortunately triggers further influx of inflammatory response, adding to the inflammation and fibrosis. And so the key concept again is there's a chronic inflammation in these patients, there's activation of certain pro-inflammatory cytokines. All this leads to organ fibrosis. And the reason why I'm mentioning this is, as my subsequent speakers will talk about, there are medications in pipeline to activate, to block these and hopefully modulate the effects. One more concept I wanted you to take home is about the reactive oxygen species. So, as you know, in our body, everything is in a balance. When there is oxidative use stress, these reactive oxygen species are required for angiogenesis, for proliferation. But when there is oxidative stress, there is fibrogenesis, tumor growth, metastasis. As you know, fatty liver are more at risk of developing cancers. We know that. So these reactive oxygen species are signaling molecules. They have, when they become pathogenic and overproduce in metabolic stress, they cause mitochondrial dysfunction and affect the mitochondrial function and endoplasmic reticulum, all leading to endothelial injury, vascular inflammation, glomerulosclerosis, and lipid perioxidation. We know 50% of all heart failure patients have kidney disease. The most common cause of kidney disease, patients with kidney disease to die, are cardiovascular. So it's kind of very much interlinked. And with progression of CKD, you start accumulating uremic metabolites. We commonly measure only urea because it's easy to measure, it's very cheap. But there are other small water-soluble molecules which start accumulating, which all have impact on endothelial dysfunction, vascular smooth muscles, on the cardiac myocyte, increasing thrombogenicity. I'm just going to talk about one of them, indoxyl sulfate. It's a protein-bound uremic toxin which accumulates in CKD, which promotes oxidative stress, inflammation, and cardiotoxicity. And this also introduced reactive oxygen production, activates NF-kappa beta, which is, as you know, responsible for turning on genes which can cause cell death, leads to endothelial dysfunction, and accelerate atherosclerosis in CKD patients. Okay. One last concept. How is the sympathetic and renal angiotensin system connected? I mean, we see that when you do these denervation for resistant hypertension. So what you're doing is you're blocking the sympathetic system, but that somehow affects the RAS system. And so there is an mRNA called MIR-181, which when its levels go down, it increases renin and renin-angiotensin. So there are some molecules now being developed which increase this mRNA, which will hopefully reduce production of angiotensin. So again, this connection which we know about causes heart failure, hypertension, and metabolic syndrome. One last molecule I want to talk about, HGF-23, which is a molecule which levels go up when you have loss of kidney tubules. When you have loss of kidney tubules, you stop excreting phosphate, which increases FGF-23 production. And FGF-23 is associated with many things, but one of the things it is associated with LVH, left ventricular hypertrophy. And we see that when you have CKD patients, they have LVH gradually. So FGF-23 is elevated as a compensatory response to phosphorus retention, and it causes LVH. So biomarkers, I've mentioned many molecules. The ones which are commercially available are BNP, FGF-23, urine ACR, and highly sensitive CRP. All this are associated with this CKM disease complex which we mentioned about. So my subsequent speakers are going to talk about how many of these new molecules are down-regulating some of these pro-inflammatory states, and we should think this as a conjoined disease where we have to work together with primary care and secondary care, endocrinologists, cardiologists, nephrologists, and stroke physicians, of course. One last plug, if I may. We're going to talk about our research lab. So I work with MBZ and KU. We have a bunch of PhD students, and I'm also always looking for young talent to help move my projects forward. And so please do reach out to me. Thank you very much.